Hi, welcome to Ideas at Work and Beyond. I'm Ed Volpin-Tesla. I'm your host for tonight. I'm a primary care doctor here in Bethel. And before I introduce my guest, I want to just remind you that this is a live call-in show. The number is 792-4101, 792-4101. Please call in with your questions. Tonight we're talking about health care. You know, whether you're rich or poor, young or old, married or single, whether you have children or not, health care is on everyone's mind. It's expensive, the system has become impersonalized, and no matter where you live, it's a problem. So we have two very important guests with us tonight. Dr. Randy Trowbridge. Randy is a physiatrist. He's a rehabilitation doctor here in Danbury. He's been in practice for almost 20 years. And my second guest is Mr. Mark Thompson. And Mark is the executive director of the Fairfield County Medical Association. And he's been doing that for about 20 years also. Mark, I'm going to start with you because, you know, you just came back from Washington. You've been meeting with some legislators, lots of doctors. Give us a general overview, just to kick this off. What's going on? What did you learn down there about the problems we're facing?
There's a lot of concern over our healthcare system, and we were down there talking about universal access to healthcare and the changes that need to be made to the Medicare program. Those are the two hot issues that were being discussed in Washington, D.C.
Mark, when they say, like, what kind of changes? I mean, you know, I've been in practice for over 30 years, and I'll tell you, over the past 5-10 years, all I hear, there are some days that I hear more problems about what's wrong with the healthcare system than I hear actual physical symptoms. So what are some of the things, just again in general terms, that you're hearing, and then I'm going to bounce it off Randy?
Well, as executive director of the County Medical Association, typically the calls that we get is that from the physician standpoint, they're very frustrated with the system.
Right.
And the calls that we get from the patients is that the system is getting too expensive. And I think that, you know, as a state and as a nation, that we need to come together. We have to very seriously talk about these problems and decide how we're going to move forward as a state and as a nation. Because one thing that we do know is that, you know, the current course that we're on is untenable, it's not affordable, and too many people are being left behind. And you know, we just can't have that any longer.
Thanks, Mark. You know, just before I go to Randy, I understand that right up at the very top of the reasons for personal bankruptcy, it's people going broke because of paying for health care bills. So this really is a serious problem. Randy, tell us what you do as a physiatrist and how some of these changes have impacted on how you run your practice.
Well, physiatry is a specialty in medicine. It's a primary care type specialty, even though it's a specialty. And we're dealing with a variety of patients, mainly in the area of pain management, but musculoskeletal disorders, and trying to get people who have lost some function back into doing what they want to do.
Randy, you know, you're a perfect example. Here you are, you've been in practice 20 years, you're in private practice, and you're really an example of the problems that people like myself have. Many of small practitioners, many of us are in single practices like yourself, or in 2 or 3 person practices. Tell me how, and I think it's important for the public to understand this. You know, you hear, gee whiz, my doctor doesn't spend a lot of time with me. I'm in the office and out. I know you don't do that, but explain to them why some of us have had to take that approach.
I started off my practice on my own about 14 years ago. I'd worked in a hospital setting before that, where I didn't have the responsibilities of the business end of the practice. I went out on my own, and as a result of that, incurred a lot of startup costs and the whole thing that goes on with starting a practice. Now, over the years, I've tried to maintain what I started off doing when I first got into medicine, and that was to provide the kind of care that, you know, was in my heart to give to people, and that was the best that I could do. it involved a lot of time and a lot of dedicated evaluation.
Sure.
And as a result of that, I began to see that if I wanted to maintain that, I would have to extend my hours as the years went on, because I had difficulty being able to maintain the practice as it was, paying for all the overhead costs that were there. One thing that's happened in healthcare is, as the costs of maintaining a practice, the overhead has gone up. There hasn't been a let's say, a commensurate increase in the funds coming from the managed care companies to allow us to maintain that level of care, unless you extend your hours over the day to provide that same dedicated time to those patients.
Right.
So it's that, along with the need to increase a staff to deal with the high cost of just the bureaucracy of the managed care companies,
Right.
made it much more difficult.
Right.
So, Ms. Randy, to do the kind of work that you want to do, and let's say 15 years ago you would put in maybe an 8-hour day to give the people that you're seeing the kind of humane treatment they want, what's your work day like now? How many hours would you say you're working now?
Well,
About.
well, I think that one wants to look at this from 2 points of view. One can either try to see more patients in the same amount of time and to deliver less time, quality care to that patient interaction, or one can just extend their day. And I've ended up extending my days to, basically a 12-hour day, 5 days a week. And that's just in patient care and not even the management end of things, which I take home a lot of.
That's amazing. You really work on it. Well, Mark, go ahead. Jump in on that.
If I can, just for a second.
Please.
The Fairfield County Medical Association is the single largest physician organization in Fairfield County.
Tell them how many people are in the organization, Mark. How many doctors?
We have almost 1,800 members.
doctors.
And we receive literally dozens of phone calls every day from both physicians and from patients. And I can relate to what Randy was just saying, and just to put it in a little bit different context, we now know that the average physician sees 40 patients in a day because they have to, in order to keep things on a status quo or an even keel within their practice. To put that in context, about 20 years ago, the average number of visits that a physician would have with patients was 24. So it used to be 24 patients a day. Doctors now have to see 40 physicians a day in order to keep their practices on an even keel. So what's been happening is patients are saying to us at the County Medical Association, and we got several of these just today at our office, the doctor isn't spending time with me, somebody else on the staff, not the physician, is performing the test, and I really wanted the doctor to do the test, but unfortunately the doctor doesn't have the time because they're off doing something else that they have to be doing at that time, so they're using other people. It might be a PA, it might be a nurse practitioner, it might be a nurse, it might be a medical assistant. And patients, they're paying a lot of money for their premium, more money than ever today for their health care premium, and they want that same quality. And I think physicians, on the whole, have been able to do that, provide the same quality, but it's getting tougher and tougher with every passing day.
Well, these are great points that you both bring up because, again, I hear this problem all the time. My doctor, I think every now and then they do these polls, and they always say, "What's your biggest complaint with your doctor?" And number one at the top of the list always is, "My doctor doesn't spend enough time with me." So I think it's important for the public that they heard that from both of you. Well, let me ask you now. This is a big world, big planet. And the way I understand it, it's only the United States and South Africa that don't have a healthcare system which is what they call a single-payer system. And, it's got to be nice to live in a country where no matter what your problem is, you can go to your doctor and get your health care paid for. Mark, you know, we've talked about this through the years. Can you tell me anything about a single-payer system so that people out there know what we're talking about when we talk about single-payer?
Well, I think for most people, when you say a single-payer system, typically it's the government, you know, that's running that healthcare system. The physicians are either employees of that healthcare system, they work for the government, or they're paid for by the government. I think probably the best example and the closest example that we have of a single-payer system is Canada. You mentioned
Right.
a few other countries. And, you know, that's been looked at, and I know there's a lot of people here in Connecticut, probably in Danbury, that feel that that's the way that we should go.
Yeah.
And then there's other people who feel no, you know, that what we need to do is to make some changes, to reform our current healthcare system just to make it better, to make it more efficient, remove many of the administrative hassles that we have. And I think it's going to be interesting over the next 6-12 months, depending on who our next presidential...
You know, you said a key word there, Mark, and
Please.
Randy will get you in on this too. Efficient. You know, they say in Canada they spend about $3,000 per capita on each individual. In the United States, we spend about $7,000 per individual, almost twice what they're doing in Canada. And yet, you know, there's an organization called the World WHO, the World Health Organization. It's 191 member nations. The United States, and I can't understand this, ranks like number 37. And France and Italy and Spain and a couple of little Mediterranean countries are way up on top. So people are saying, you know, here in America we spend so much money, and we have good doctors, we have cutting-edge technology, we invent a lot of the technology, yet we're not getting our bang for the buck because we're not being efficient. Right? We're using more technology, more medicines, but our people aren't necessarily living longer. We're not getting our money's worth. Randy, can you tell me, what do you think? Is that something you'd like to?
Yeah, I think there are several factors that contribute to that. I'm only going to touch on one here, but I think the biggest issue that comes up in the area that we're talking about tonight is the idea that a lot of money is spent on things that are not directly patient care. And as a result of the many layers between the monies that are available for health care and the delivery of that health care, I think we're losing a lot of that money in areas that, as you said, are inefficient. And what I'm saying is you got managed care companies in this country who are, I think, arranging or developing plans that do two things. One, require a lot of extra work on the part of office staff in medical offices, and additionally are, on their own end, highly involved in, well, have a lot of members in their own organizations that they're paying for. So you have a very large managed care company in between the healthcare provider and the patient, and that is, you know, obviously contributing to a lot of the high cost.
They say that managed care, which for the audience is, for you folks, is HMOs, covers about 161 million individuals, Mark, something like that. Now here's the thing that I don't understand. Here we are complaining about health care. How can you have a health care system, right? I'm the patient, Randy, you're the HMO. How can you take care of me when in between I have to worry about stockholders? How can you really do a good job for me if you have to generate money to keep stockholders happy and also to pay some of these fantastic salaries for the CEOs? A few years ago, there was one CEO, I won't mention the HMO, but he was making $3 million a year. And oops, we got a phone call. Let's hear what they've got to say. Go ahead.
Yes, good evening.
Hi.
I have a two-part question, please, on universal health care.
Good.
First part is, I'd like to know, do we have the capacity to provide that care? And secondly, who would pay for that? Thank you.
Thank you, caller. Mark, why don't you take that first? Do we have the capacity?
Do we have the capacity? That's a very good question. I think presently we probably do have that capacity, but there are, I think there are some concerns that we all should have. At our current course, we know that unless we train more physicians over the next 10 years, that by the year 2020, we're going to have an 85,000 physician manpower shortage in the United States. We are just
how many? 85,000.
85,000 across the whole country. I think that, you know, here in Connecticut, we're very fortunate. We have a very high percentage per population of physicians, but I can also tell you that that's changing every day. We are having a very difficult time attracting new, younger physicians to come in and to work in the practices that we have here in Fairfield County. It's one of the biggest complaints that I hear from medical practices across the county. And the reason for that is because the cost of living is very high in Connecticut, particularly in Fairfield County. And number two, the salaries of what medical practices are able to offer to young incoming physicians, it's either on par or it's below what other parts of the country are able to offer. And I'll just give you one example. The cost of medical liability insurance. That's one of the factors that physicians have to look at.
Mark, I'm going to interrupt you because we have another caller.
Okay.
And we want to get as many people as possible responding. Go ahead, caller.
I've all been tested. It's only me.
Only who?
Only Citizen X here in Bethel.
Oh, great.
You haven't been going after our lawyer friends lately in the paper. I really miss that.
I know, me too.
All right. Listen, to our guest, do you have any idea what proportion of the population of England and in Canada, where they have socialized medicine, what portion of the population carries their own private insurance because the system is so deficient? I have many friends from Canada and England, and they tell me the horror stories is not as good as we hear it is. And again, I don't know if you folks know Dr. Davis, and he practiced in Canada. And I just meet a lot of people in my line of work. And again, do you have any idea? The system is so deficient. From what I hear, between 20 and 30% of the people in England and Canada have to have their own private insurance because the system stinks.
All right, let's see.
Say that, use that adjective, but it's just deficient. So, did you hear that also?
All right, we're going to let Mark run with the ball on this one.
By the way, Doc.
Yeah.
Can you hook me up with that stuff there, that red grape derivative that they came up with that's going to extend your life to 150 years when it comes out?
Yeah, I'd like some of that too.
See ya.
I'll share it with you. Thanks for calling. Mark?
Well, there's an interesting phenomenon that's going on in England. There they do have a national health care system, but the employers and the employees there, they can actually go outside of their national health care system. And that's a highly desirable, sought-after kind of a thing. They actually negotiate with their employers to get an insurance plan that's outside of their national health care system. And the reason for that is because they do ration health care, and the waiting lines for services, if you need a hip replacement surgery, I learned just the other day that the wait now, if you're within the age where they will do a hip replacement surgery for you, is anywhere now from 4 to 6 months. Here in Danbury, Connecticut, you probably can have that done within a week or two.
Exactly. And to the caller, you know, the question is a good one. The question always comes up, you know, national health care, socialized care with these horrible connotations. But you got to remember one thing: if we do it in this country, it's going to be an American system. It's not going to be a European or Canadian system. And we're resilient people. We demand the best, and we'll get the best. So I think that, you know, when you say social, you know, let's put it this way. Ever since 1940, the opponents of national health care have always said socialized medicine is bad. And they tried to compare it to, you know, Russia and these communist countries. But the truth is, a national health system, if done right, if done the American way, could be very good. Mark, just very briefly, the previous caller said, who's going to pay for it? Well, You want to take that maybe out of taxes, or?
Well, you know, the way they do it in these other countries, they have a much higher tax rate than what we have here in the United States. And I'm not sure that we're ready to tax ourselves as high as they are in these other countries, in my opinion. But, you know, but I don't have a crystal ball. But I was down in Washington, D.C. for the past couple of days. I had an opportunity to listen to many policy wonks, to lawmakers, to political strategists. And I think that we probably have one more shot at transforming our healthcare delivery system, and it will still include the insurance companies. I think they'll have one more chance to get this right, and if they don't, then I wouldn't be surprised that we don't try a truly socialized national healthcare system.
Right. And the previous caller in had mentioned what are some of the problems. I know that in Massachusetts, I forget how it all began, but a few years ago they tried to mandate health care for everyone. So you had to sign up you had to have your own physician. Everybody had to have a physician. And you know what the problem was? There weren't enough primary care doctors to go around. So suddenly now you had everybody who had all this insurance, they're ending up in the emergency room for their care. So one of the things that this World Health, this WHO, World Health Organization, has made very clear, and the reason why the United States is number 37 out of 191 is because we don't have the right balance. And by that I mean, in most of the world that has national health care, you have 50% are in primary care and 50% are in specialty medicine. Here in the United States, it's about 35-65, so the balance is wrong. Another thing is that you have to have the right number of nurses. And you know, and you go into some hospitals, you got one poor nurse at 3 o'clock in the morning taking care of 20 patients, and who's falling off a bedpan, and who's pushing their buzzer for this, who's pushing the buzzer for that. That's a problem. We need more nurses. So it's a multifaceted problem. Go ahead, Mark.
And I think that another reason why the United States, we're not getting our value for the dollar that we're spending on our medical care delivery system is because our system is backwards in sense.
Yeah.
And I'll just use the Medicare program as an example. 80% of the money that's being spent for our premium dollars that go into the Medicare program, 80% of those dollars go towards what's called the end of care, the medical care that you receive at the end of life, and only 20% goes towards preventive services.
Right.
When you look at our commercial insurance plans, our Medicare plan, the emphasis, there's not enough emphasis on preventing diseases in the first place. And I know, Randy, that you've been very big on that. You're a firm believer that we should be spending more time, more of our energy, more of our resources on preventing diseases from occurring in the first place.
Good. Well, you know, we were talking, Randy, I'm going to throw this one at you, is, I mean, one of the, I mean, and I don't want to criticize our politicians because they have a lot on their plate. I mean, you know, you've spoken with these people, I have. They have so many issues that they have to deal with. And healthcare is so complicated. I mean, God, it gets more complicated every day. And why haven't we challenged the insurance industry and the pharmaceutical industry? I mean, it's got to be political, you know, I mean, you got the Republicans who want to, you know, kowtow to the both of those, you know, to the private industry, and you got the Democrats, and they're almost doing just about the same. What do you think?
What I see out there is I see a number of different components to determining our healthcare system that we're talking about for the future. And probably the most significant factor limiting our involvement in making those decisions.
Excuse me, Randy, I got a phone call. Okay, caller, you're on.
Thank you. Hi, Dr. V. This is Kathy from Danbury.
Hi, Kathy.
I just want to go in a little bit different direction.
Okay.
How do the Medicare doctors determine the number of days that someone can stay in a facility or go for therapy? Do they take a poll or something?
That's a good question, and we got just the guy who's going to answer it for us. Any more you want to add to that?
No.
Okay.
Thank you.
Okay, Randy, you got that one?
Yes.
How do we...
I honestly can't tell you the exact details on what's going on in determining how much care can be delivered. Certainly there is a limited number of funds to pay for health care. And when you look at what we want, what we expect as Americans, and what amount of money is there, it has to be divided up in some fashion. Now, there are a lot of pressures going on to obviously lower the amount of cost going into healthcare. And as a result of that, somebody's making a decision about, for a particular condition, and there are some, well, there is some scientific data going into this in terms of trying to come up with a figure, a number for the average person having an average condition and how much money it's going to cost to deliver that care. But the thing that I think is missing in a lot of that is accurate information from the healthcare providers. I think we're getting most of that information from the insurance companies and their group of medical professionals who are trying to come up with the actual number that's going to be allotted for a particular condition.
Thanks, Randy. Mark,
I can also add, and it's been a number of years since I last worked for a hospital, and at the time that I did work for a hospital, they didn't actually have this in place, but I believe that Medicare is also reimbursing hospitals. I'm assuming the caller was asking the question as it related to hospitalizations. But the Medicare program now is reimbursing hospitals based upon something called DRGs, diagnostic related groups.
Right.
And they're telling the hospitals, if you admit a patient for a certain condition, we're only going to allow so many days for that particular condition. So the pressure, the incentive then is for the hospital to either come in on that number or below that number, because if they do, they make a little bit more money. And for every day that the patient may stay in the hospital that's over that particular DRG, what they agree to reimburse a hospital for, then that actually works against the hospital.
You know what's disturbing, Mark, is that in simple terms, it really does all come down to money. You know, I'll tell you, I've been reading in the paper over the past few days, Medicare and some of the private insurers are going to follow suit. They're not going to pay for what they call preventable errors. So if you're in the hospital, and something happens bad in the hospital, and somebody says, you know, that person shouldn't have gotten that infection in the hospital. I don't know how the heck they determined that, but if they determined that person shouldn't have gotten that infection, or they fell off their bedpan or whatever, the hospital's not going to get paid for the work they did. And what's happening is everybody's passing the buck. So Medicare, you know, in managed care, they're going to say, you know, we got to save money, we got to increase our profits. We're not going to pay for air. I mean, that's scary. That's scary.
Well, it is. You know, the Medicare program, I believe that they have come up now with a list of about 8 or 9 procedures. They're calling these never events. These are events that should never occur in a hospital setting. And again, I think what they're trying to do is provide financial incentives, or maybe in this case, disincentives if something occurs. And I think it's tough to argue that if somebody gets a hospital infection and it's an infection that could have been prevented by hand washing, then the hospital needs to work harder with its own staff to make sure you know that the staff, you know, that they do wash their hands.
Thanks, Mark. We got a caller. Let's see what we got. Yeah, go ahead. Oh.
Hello?
Hello, you're on.
Dr. V?
You.
Faye?
Go ahead, Faye.
I just want to know why doctors are not visiting their patients in the hospital anymore.
Good question, Faye. And Randy, why don't you thank you, Faye. Randy? She's talking about hospitalists, obviously, yeah.
No, I understand. once again, we're trying to, as you said before, deliver health care in an efficient way, and costs have become the biggest overriding issue for the people providing the cost, paying for the health care. And as a result of that, the way to efficiently deliver that health care is to have primary care doctors at the office setting stay in their office, take care of their patients, and have a person who's trained more specifically for those hospitalized issues, those conditions requiring hospitalization, to take care of that person in the hospital. And as a result of that, doctors are actually finding it from an efficiency point of view easier for them to manage.
Hope that answers your question, Faye. It's a problem. Everybody's trying to control cost. I mean, that's really what it comes down to. Sorry, Faye, we got another caller. Go ahead.
Dr. Volpentad, sir?
Yeah. Go ahead. Can you hear me?
Yes, I can.
Go ahead.
Hi, Doc. It's Lee.
Hi, Lee.
Listen, yeah, it's me.
Oh, Lee.
Yeah.
Good.
I have a question. I was wondering, when you go to the hospital and you go in a room and you get in, and first of all, you can't see your own doctor, but then, 4 or 5 doctors come in, and, you talk to them, and they talk to you, and they leave. And then after that, about maybe half an hour, 4 or 5 more doctors come in, and they ask you the same questions. And it's like, okay, I just told somebody all these, all the answers they want. I got to say it again. And this goes on for as long as you're in the hospital. It could go on 3, 4 times a day. And then when you get home, you get a bill, and you get a bill from everybody. And it's like, what's going on?
Well,
if you have high blood pressure, forget about it. With seeing these people 3, 4 times a day asking you the same questions, I don't know what else to do about it.
Well, good question, Faye. I think you're making my blood pressure go up too, Leah. Thanks, Leah. Let me throw that one to Randy. Thank you, Leah. Randy, why do so many doctors visit a patient when they're in the hospital? We've all been training. Go ahead.
I think there are several reasons for this. I think, first of all, in this community at Danbury Hospital, we have a teaching program. We have residents who have to be taught, and as a result of that, they are going to be participating in the overall care of the patient. Then we have doctors who come in who may be the primary care, or the hospitalist in this case, who's addressing the primary problem but identifies other areas that might need some special attention. Some of that's warranted from a medical management point of view, and other times it's actually doctors concerned about the potential for liability issues coming up, and they want to get a specialist's input into that care. And as a result of that, you're going to have a number of people coming in to evaluate you and come up with a treatment plan.
Thanks, Randy. Lee, I'm going to let you go. We got another caller. Go ahead, caller.
Yeah, good evening. It's a great discussion you guys are having, very helpful. I had a question regarding pre-existing conditions and chronic illness. I was aware that Medicare's big problem was the fact that chronic illness was a big part of the cost driver. And my question was, what do you guys think about pre-existing conditions and chronic illness, and how do we deal with that in a fair way that makes the system whole? That was my question.
Thank you, caller. Great question. Randy, run with that one.
Yeah, we have
pre-existing condition, cherry picking, right?
Exactly. Yeah, I have, I've been dealing with chronic pain, chronic ailments for a long time, and I see this all the time. I see people coming to me with various conditions that have been there for many years, trying to deal with the insurance company in that area is really an issue, again, of their concern about the rising cost of health care, trying to select patients for their particular company that are not going to run those costs up high, and obviously they're going to end up with higher costs for these people who have these chronic conditions. I think it all boils down to a couple of things. It's really the cost of health care again, and what we want, what we are expecting for the money that we're willing to pay as a community for health care. And I think it also brings up the issue of responsibility for developing or getting into a situation where you have a chronic condition. It gets into a whole area of preventative medicine. So I don't think we spend enough time in our health care management in truly preventing conditions that get to these chronic conditions.
Thanks, Randy. We got 2 more calls. I'm going to cut you short, buddy, okay? Okay, caller, can you hear me? Hello?
Hi, Dr. V. It's Katrina. How are you?
Hello, Katrina.
Hi.
Thank you for calling in.
Personal office manager type person.
Where do you work, in the doctor's office?
Yes, I do.
Oh, good.
And we deal with this every day, and the time spent with patients and the time spent with the insurance companies and the time that we put into it. And I'm not sure if it's an opinion or a question about the time that we spend. Is any suggestions? Or, because I know we spend a lot of time on the phones with insurance companies. Any help?
Randy, thank you, Katrina. Well, you know, Randy, that's something that's a real nuisance. And people don't always understand that. It's not just the doctors, but it's your staff. I mean, they spend a lot of time. And, you know, Mark, it's not just the time. It wears you down. Sometimes the patients come in and they say, gee, the nurse was a little short with me. It's because the nurse has been beaten down. She just got off, spent 10 minutes fighting with somebody in a managed care or the Medicare office. Go ahead. What do you...
Well, first thing I noticed is this caller sounds very tired. She sounds very tired, and I see that in my front office. I think for a private practitioner like myself, although I do have some physical therapists in my practice, having 8 or 9 people in the front office is a lot of people there to cover and take care of issues. Even with that, I get the same response from my front office. What's really going on there is is 2 things. One is that managed care companies are shifting the responsibility of all of that. Shifting the responsibility of all of the need to get approvals and everything else that goes along with actually being able to deliver the care onto the practice, and as a result of that, it's taking its toll on the people who have to work every day like that.
Mark, you were anxious. Great, that's a good answer. Did you want to throw something in there?
You know, something that I've observed over the past couple of years is a lot of these insurance companies, in their quest to boost their profits, what they've been doing is they've been cutting back on their provider relations staff. That's putting more work onto Randy's office to try to chase down claims, to find out what's going on. I'd be willing to bet that he's probably had to add on 1, maybe 2 people just within the past couple of years because of this phenomena that's occurring. The insurance companies, they want you to use these toll-free numbers. And when you can get through, a lot of times it's difficult to understand who you're talking with because they're actually not even here in the United States. These are people that are answering the phones, but they live in other countries. The insurance companies want you to use their online, their websites for answers. And
Mark,
it's good for some things.
We got 2 more callers, and this is wonderful, so I'm going to interrupt you. Go ahead, caller. Go ahead. You're on.
Yes. If universal health care becomes enacted,
yes,
who will have oversight? Thank you.
Thank you, caller. Mark?
Yeah, you know, that's very difficult to say because universal a health care plan, it depends on, you know, what that plan looks like. You know, there are literally dozens of plans, proposals that are out there. Which one's going to surface and which one's going to be implemented, it's very difficult to say.
So we got to get more doctors into the system. I mean, you know, here we are, 2 doctors, healthcare administrator. You look at TV, I won't mention the channels, but you know, you look at TV, you hear presidential candidates all the time arguing about health care, and they're talking so vaguely. I mean, I'm a physician, I don't know what they're talking about, and I think they hoodwink the public. What bothers me is that, you know, you've never seen a physician. I've never seen one of the politicians have a physician at the negotiating table. I've never heard of Randy Trowbridge's opinions being expressed, or yours, or mine. You know, I was reading Barack's book, The Audacity of Hope. And one of the chapters that he mentioned He was talking about the plight of the African Americans and how they, you know, how hard they had to fight for liberty. He said, you know, it was very clear that power is never given up easily. Yeah. Power requires a fight. I mean, there's no simple way to talk about this. The HMOs, pharmaceutical companies, they're powerful, they got lots of money, and they're getting away with murder. Physicians are not allowed to unionize. I mean, you talk to some of your friends, they'll say, well, gee, why do you guys and women, why do you take all this from the HMOs and the pharmaceutical companies? Why don't you unionize and do something? Randy, why don't we unionize?
We're not permitted to do so legally. We are in a situation where laws, you know, antitrust laws prevent us from collectively getting together and being effective negotiators with the managed care companies in order to come up with a fair way to come up with proper health care.
You see, I don't think the HMOs or Medicare or the pharmaceuticals are ever going to treat physicians and patients fairly. So, Mark, how do we muster that political will? I mean, I think the only way that this healthcare system is going to get better is if physicians and patients have got to draw the line and say, that's it, we're not going to take it anymore. I mean, you know, Randy, Mark, we've been in this since 1990. We have gotten nowhere. We've talking to legislators, and again, I'm not picking on the legislators. It's an honorable profession, but they are so beholden to so many outside interests. And physicians, we're pushed aside. We're never even part of the dialogue. Thank God we're here at Comcast tonight getting our word out. What do we do to get our word heard nationally? Mark?
You know, Ed, you know, we're doing everything we possibly can as an organization of physicians. As you know, I was down in Washington. I'm up at the state capitol. Our state medical society is the voice for medicine. Yeah. Why we're not at the table at many of these very important discussions, or when we are brought in, you know, it's frequently after many decisions have been made. You know, I have to admit, you know, the insurance has a very strong lobby, business has a very strong lobby, the unions have a very strong lobby, and probably even stronger than ours. You know, we do everything we can, we do the best we can, and what's really sad in all this is that physicians are their patients' best and strongest advocates. Right. You know, we're there every day, you know, to help them with their problems, to relieve their pain. We want the best for our patients, but it's a classic case of a conflict between, you know, the quality and the utilization of healthcare services versus the cost. And you said it earlier, Ed. You know, a lot of these problems seem to center around the dollars and cents of things, and that's I think that's exactly what it is.
Let me get this caller. And by the way, the number is 792-4101, and we're getting lots of calls, and this makes me feel good. Go ahead, caller.
Hi.
Hi.
I can see that the doctors are angry and frustrated with the current system. I'm wondering, why would a young person today want to join in a system as a doctor where they can see that the doctors appear unwilling to organize and really fight the system in an effective manner, like, say, withholding services for a day nationally across the nation to make a statement against the healthcare organizations?
You're my kind of guy. I'm going to let Randy answer that question. Great question. Thanks for asking. Randy.
Our profession as physicians, I think, is a unique one. I'm not saying that we're the only ones who do what we do in a sense for people, but when you take an oath as a physician to care for other human beings, you have both a privilege to deal with their problem, with the intimacy of just getting to know a patient, having them share with you the problems that they're having, and that's a very special thing. With that comes a lot of responsibility, and as a result, we are really trying to, number one, deliver the best possible care and advocate for our patients. The problem that we end up having is the inability to effectively get out there and speak our minds, because we don't want to give up the quality care. We don't want to tell a patient we can't take care of them.
You're too dedicated
and at the same
to your
time, so if we were to take a day off, so to speak, and there's a conflict within the inside of our essence as healthcare providers to do that, yet at the same time we're also prevented in a legal way. I would be the first one on the front lines if everybody collectively as healthcare providers said we're going to at least demonstrate in a way that we're not going to provide care for a day for patients. I would be torn inside because of what I think could happen to certain people as a result of that.
You have integrity, of course. Mark?
I think that's probably the best answer, and that's the real reason why most physicians don't come together and boycott the insurance companies. And I believe everything that you say, Randy, is true. But from a legal standpoint, before I came here to Connecticut to work for the physicians, I did this up in upstate New York. And I worked for them at the time when they had their medical liability crisis in the mid-1980s. And one of the things that the physicians there did, and these were the orthopedic surgeons, and there may be some people out there that remember this, I remember very well, the doctors started to organize, and they said, the orthopedic surgeons there said, we're no longer going to do elective surgery until the state legislature acts upon medical liability and fixes the problem. So slowly around the state, orthopedic surgeons stopped doing elective surgery. Well, I can tell you that the government and the judges came down on that very hard. They actually took 8 physicians, they put them in jail for a week. In fact, we called them the Long Island 8, and they also heavily fined and penalized those doctors. So that's probably the best reason, next to Randy's, why physicians, they don't do this. Government doesn't take it lightly, and what doctors provide to the community is a very valuable commodity, and well, not a commodity, but very valuable service, and we don't want to withhold that service.
Right, Mark, Randy. So let me just summarize. Okay, we have a system that is making people go bankrupt. Right up there,
including some physicians are even going bankrupt.
Even doctors.
And it's a Hobson's choice. Yeah. Either you keep providing service and you go bankrupt, or you don't provide the service and you can't make a living not doing that either. It's a terrible situation to be in.
Right. So we got a system that is making people bankrupt. We got a system that is losing its cardinal characteristic, humanity. Right? We're losing that. People are seeing doctors in the system as cold. We're seeing a system that we feel being taken advantage of by insurance companies and pharmaceutical companies. It's been going on for at least 15, 18 years. Things aren't getting any better. To me, the answer is we have got to muster the political will, and that's where you, the public, comes in this equation. Us three, we can't get much done, but if you speak to your legislators and you let them know how unhappy you are, and you can't be shy about this. They're busy. They've got a lot of things on their plate. Healthcare is just one of them. But until we hold their feet to the fire, we're not going to get much activity. I personally don't believe that the pharmaceutical companies and the HMOs give one damn about me and him. And I'm not so sure they care that much about the patients. They've got shareholders that they've got to generate profits for. I mean, there's a principle that's involved in. I keep on coming back to that because it's got to be addressed. Randy, you're burning the commit.
I got to say something about this. A perfect example of this, and I think everybody should listen up very carefully to this. This is one example, and it happened really in the last several months in a number of cases that I've heard about and experienced in my office. I provide physical therapy, and I've had a number of patients who are pregnant who've come to my office in their later months of their pregnancy, and as a result of their pregnancy, developing some back and pelvic pain. I had one patient who was brought into my office in a wheelchair, and interestingly, there are some insurance companies out there who, because this individual is pregnant, have denied them the care that they need. Back pain, pelvic pain, and any other circumstances covered for their physical therapy is covered, but because they're pregnant, there's some fine print in their policy that says no physical therapy because you're pregnant. Okay, here you have insurance companies who have decided to create a little carve out so that they can save money with no regard whatsoever for what could potentially be the best treatment for that individual. That mother doesn't want to be taking medication because she has a child. She's carrying a child. And the best things that have been found to manage that, and there's medical evidence to substantiate this, physical therapy and acupuncture during pregnancy. And yet it's not covered under certain insurance plans.
They're just trying to get out of their financial obligation.
Yeah.
It's ridiculous. Mark?
Ed, I've had the good fortune
You got about 3 minutes, guys.
and the honor and the privilege to work for the physicians of Fairfield County since 1990. When I moved to Connecticut, there wasn't a single for-profit insurance company in Connecticut.
Wow.
Here we are, 2008, and we don't have a single non-profit insurance company. The insurance industry is taking off roughly 20% of every healthcare dollar that's being spent. This is money that's not even going towards any patient care at all. 20% off the top for administrative costs. You said a couple of times during the show here tonight to pay the shareholders and the people on the board of directors and the CEOs and everything else. You know, just astronomical amounts of money. This is wrong, and this has to stop. And I'm heartened to see that many of the proposals that are being given serious consideration down in Washington, D.C., they're going to tell the insurance industry, you can't have 20% anymore. We'll let you have 5%, we'll let you have 10%, but you can't have 20% because this is our hard-earned money that's not going towards any health care.
I hope they have the guts to keep that challenge before them, Mark, and they don't succumb to the pressures that the insurance lobbies and the pharmaceutical lobbies are putting on them. I'm getting some signals that we're almost time to wrap it up. A few more minutes. Okay. It's interesting. They did a recent study. You know, we talk about national health care. 10 years ago, Randy, you and I know this, if you mentioned about a national health care system, doctors would string you up. Last year, a study done at the Indiana University showed that about 49% of the doctors were in favor. This year, it's 59%. So doctors are finally throwing up their hands, saying, I have had it. Randy, I'm sorry, we got 1 minute to go. I'm going to wrap this up for you folks. My guests, thanks for coming, guys. This is such a big, difficult, complex problem. We've scratched the surface of the surface. I hope that you enjoyed this program and that you want us to come back. In summary, we're unhappy with the healthcare system. It's too expensive. It's becoming too inhumane. It's losing the personal touch. The only people who are going to make it better are you out there. Talk to your legislators. You can call me, call Randy, call Mark. If we put pressure on our legislators and let them know how unhappy we are and how they've got to have the guts to challenge the insurance companies and the pharmaceutical companies, nothing's going to get done. And I want to thank Lou, Ivan Alcime for inviting us. Thank you. Good night.
Thank you, Ed.
Bye. Thanks, guys.
Thank you.
And so we're going to keep going.